Good morning. Uh, Welcome back to the vestibular section for PT on Ice. It's RJ again, and it is Thursday morning here out in Las Vegas. Hope everybody's doing well. We last covered this a little bit about a week and a half ago on a special Tuesday session where we did Bppv part 1, and we went I think a little bit longer than usual to cover a lot of the fundamental pieces and start to talk about Bppv in the posterior canal, which is going to be the most common variant we're going to see in our clinics. And today I wanted to wrap up some of the basics from posterior canal and begin to talk about how we diagnose lateral canal. And so some things that we're going to look at with lateral canal are the fact that we need to use a confirmation test of using both sides, so head or body laying right and left, to confirm intensity and direction of the eyes that they're beating, but also we can use some secondary tests. We're going to talk about the bow and lean test today to help us kind of reassure our thought process of what we've got going on. So just to come off of where we were with part 1 back in last week when we were covering this, we're going to start the patient on the side of the bed. We're going to rotate their head 45 degrees to the left or 45 degrees to the right, and then we're going to take them back with their head extended off of the table, generally to get about 20 to 30 degrees past neutral from where we are. And this can get tricky for some of the patients that you may be seeing. So sometimes we have to be creative in how we're going to treat these cases. So one of the things that I'll use with some older adults that may have some upper mobility issues in the neck and spine area is using the assistance of a pillow or changing the angle of the slope of my table. So what we're relatively looking is for that head and neck on body to achieve a declined position from where their rest of their torso is. So gravity is going to have a downward sloping effect to pull that debris down through the canal and create action. And so I was teaching recently at one of our local PT schools here, and what we were having the conversation is that Bppv can be a bit of a pathology that is a hyperactivity, where most of the other cases that we're going to see here in Las Vegas or in any clinic, most of the cases that we're going to see for physical therapy for Bppv are hypoactive systems. So usually the system's not working quite as well. In this case, the debris is moving through the canal and it's causing kind of more irritation than we normally would have. And that's firing the nervous system to create this perception of spinning that shouldn't be there. So we take this patient down. The debris needs to move through the canal. The way that that's going to happen is by gravity pulling on it in the direction when the head starts to tip back. So we can get creative sometimes too if we're struggling with patients that may not have the cervical mobility, or we may be concerned as the clinician to put them in some of these positions. So if you've got a table that can slope at all, you can put their head on the lower end of the table, and you can do things like putting a pillow kind of up around their shoulder area, which is going to kind of relatively create a little bit of extension above it. And then how you're cradling their head is going to help that as well in supporting it. This is one of those things when you're doing it with patients that you have to also recognize as a practitioner that you're asking them to do something that is generally pretty noxious and uncomfortable to them. So you have to be prepared to be a really good cheerleader in this circumstance, because you don't want this patient to become very anxious and panic if they're in that position at all. You want to maintain good body contact, good hand contact, good verbal communication, as good as eye contact as you could be making throughout the entire procedure, to let them know kind of you're in command, you're in control, and you're going to be taking care of them. So in our example for the posterior canal, where we're doing cannulate repositioning, and we're doing, good morning, Matt. We're doing the procedure, and we've taken them down with that head extended off the edge of the bed, and we're watching for the eyes. The classic sign that we're going to get really excited when we see is that upbeat torsional nystagmus that generally is going to come on. It'll be pretty strong and robust, and then it's going to fatigue out. And people ask a lot, what's the right rule of how long that I'm supposed to be here? And if you saw or were able to listen to the last episode that I did, one of my favorite phrases is that bodies don't read textbooks. And I think it's very difficult to say, like, every patient needs to be in this position for 30 seconds, or every patient needs to be in this position for 2 minutes, because I think it varies between a lot of cases. And I don't necessarily say we need to err on the side of over treating it, because again, if you have a person that this is a very unpleasant position for them to be in, the last thing that I kind of want to do as the practitioner is make them stay there longer than they need to. So for me, I like to get to that position if I see the classic signs where the eyes start to beat, they fatigue out, the patient may start to report the symptoms or the intensity diminishes, and then I'm going to say, okay, how are you feeling? Things are calming down a little bit. The patient says, yep. I may stay for maybe at most 10 more seconds before going to the next position. If it seems like I was unsuccessful in my maneuver, then I may come back on future maneuvers and spend a little bit more time there. But this is a circumstance where, for me, less is more. If I could get away with I don't want to say torturing them less, but putting them through an unpleasant experience as quickly as I can, my preference. And I've found that in a lot of cases, it doesn't cause me problems. So if you're looking for a hard, fast rule, I think the guideline that I use personally is look for any observable change once you have change for the positive, and then the patient kind of supports that. Within a few more seconds, you're usually pretty safe to move to the next position. And so we talked about in the last episode, I believe, where when we go into position one, the debris is going to move through the canal because gravity is going to affect on it. So we should expect to see some symptoms there. When we pivot the head 90 degrees to position two, the debris in the canals aren't really changing in anything other than where the openings from the semicircular canals are kind of pointed. So the most lowest point in the canal isn't changing, but the canal is going to rotate around it. So we shouldn't see much action happen in positions 1 to 2. Now, that being said, there's always the likelihood that this person may have bilateral Bppv. So you may have an upbeat right torsional nystagmus when you're in the first position, switch head to position 2, which would be the same position you'd be coming in if you were testing the opposite side. And they may have nystagmus that occurs in this position that's upbeating left torsional. You have to respect that there's a potentiality that you have it in both ears. And in that case, my preference is treat the worst side first. Which side are they more symptomatic on? Or what side seems more intense when you're testing it? That's usually the one that I want to treat on day one. And for me, this is again just a preference thing. I like to try to see if I can resolve one side and then give them a day or two and then come back in and clean up the second side. Usually the second side is less intense. And sometimes you just get lucky by treating the one side and getting the head moving. You may capture some of that debris out of the other side to go away. And then when they come back, you don't have it in any side. But if you can always treat the worst of the two first, people are a lot happier coming back in. And then you have a good opportunity to just kind of clean up the second piece that's usually not as bad. So when we move into position 3 and now we go another 90 degrees and we're kind of nose angled down towards the floor, the debris is going to start moving again. So we should expect to see some symptoms or a report of some symptoms from the patient. If you were able to continue to look at the eyes, you may see some change in the eye position again as you take them through that position. And then we're going to come up and we talked about maintaining good contact here as we set up from there. But now what we want to look at is lateral canal BPPV. And where lateral canal BPPV is tricky is if you take your arm out to the side and you kind of flex, I should say, like, probably if we're like Mitch Babcock here and we're going to flex our arm to create this kind of U shape. So if I go from my shoulder down to my elbow, it's going to slope downwards. And then from my elbow back up towards my wrist and fist, it slopes upwards. Now this in my lateral canal is set horizontally and slightly pitched upwards. But when I lay down on my side, I now have an upward facing U for my lateral canal. And if the debris is kind of in the posterior curve, it's going to move down towards the direction of my fist, which is going to create fluid flow or an excitatory response out of that ear. If the debris is in the front part of the curve, where my wrist is down towards my elbow, when I lay down on that side, it's going to move down towards my elbow rather than up towards my wrist. So in this case, it's going to move away from the nerve that's going to be excitatory, and it's actually going to cause an inhibitory response. So because we have this pattern where, depending on what half of the system it's in, is going to change the neural activity in that system, we can have two different types of outcomes. So if I'm in the back half, it's going to move down and cause an excitatory response. And if it's in the front half, it's going to move away from my fist and cause an inhibitory response. Let's come back and talk about some of the Ewald laws that we were talking earlier in one of the vestibular calls. We know fluid flow towards the ampulla and cupula in my horizontal canal is excitatory. And we know my VOR system has an inverted relationship where ideally for every degree of action out of my ear, my eyes are going to move in equal but opposite direction from it. So in this circumstance, if my body starts to think that I'm turning to the right, my eyes are going to drift to the left, and then the reflexive response of them is going to be to beat back to the right. So if you were to sit and I wasn't moving and my eyes were going to react from this, my eyes are going to drift to the left and then beat to the right, drift to the left and beat to the right. So in our case where I'm laying down on my right side and the debris is in the posterior aspect of this canal causing an excitatory response, my body thinks I'm slowly turning nose down. So what you see is my eyes are drifting slowly upwards, and then they're going to reflexively beat back down towards the floor. What's interesting about this is now if I flip over to my left side, the debris is going to move away from my elbow down towards my shoulder, and what I'm creating is now the reverse response. So I'm inhibiting my right ear, which in turn, because we have always this resting tone that is slightly active, my left side seems to be the ear that's excitatory. So my body is getting the sensation when I'm on my left side that my left ear says that we're turning towards the left. So if I'm turning down towards the left, my eyes are going to drift upwards and then reflexively snap back down towards the left. So using the same circumstance in both cases, when I go to the right, my eyes are going to beat to the right. And when I go to the left, my eyes are going to beat to the left. So the nystagmus in this example reverses. So we can't call it a right beating nystagmus or a left beating nystagmus because it changes direction based off of the position that we're in. So they've given it a different name, and we call that Jia Trophic. And Jia Trophic nystagmus means geo towards the earth, and tropic meaning the way that we name the movement here. So as we're coming down, if I've got geotropic, that means I'm going to be right beating when I'm on my right side. and I'm going to be left beating when I'm on my left side. That would suggest to me that I've got some lateral canal involvement, most likely, if I'm following my usual patterns. Now, we have to look at intensity. So if I'm laying on my left side and my right ear is being inhibited, I'm left with a relatively active excitatory left ear. But that's going to be pretty minimal because it was sitting at its resting tone, and what happened is we shut the other side down a little bit. So we're left with a relative excitatory response over here, but it's nothing dramatic. If I come to my right side, my left ear should be slightly inhibitory. My right ear might be a little bit excitatory, but now I have this debris moving through the canal that is increasing the excitatory response. So I'm getting a much stronger excitatory response than when I was left with a relative excitatory response over here. So on this side, the excitatory ear is actually being increased. So the intensity of the nystagmus should be much stronger on this side. So when you lay down and you compare my right Jia Trophic Nystagmus and my left Jia Trophic Nystagmus, in this case, it's going to be stronger on my right side, and that's going to help me start to confirm that it's in my right ear. Now, if we take the same example, but instead of being in the back side of my arm, we talk about it being in the front side of my arm. When I lay down on this side, the debris is going to cause relative inhibition because it's going to pull the fluid away, and fluid flow away in this canal causes an inhibitory response. So if I lay down on my left side, what starts to happen is my left ear seems to be relatively excited. So my body thinks I'm turning to the left. In this case, my eyes are going to drift downwards and then reflexively snap up or away from the earth. And we call this either ageotropic or apogeotropic in a lot of the literature. If I come down to the other side, now in my ear on this left side, or sorry, on this right side, I've got the debris coming down, causing an excitatory response that is very strong because the debris is pushing down now almost directly onto the sensor in my up ear. So my body thinks I'm turning to the right. So my nose is coming up to the right, my eyes are going to drift down to the left, reflexively snap in the upwards direction. As this happens on this side, because again, this is the debris causing excitatory irritation, the excitatory response is going to be much stronger than when it was inhibitory over here, leaving just a relative excitation on this side. So we come here, now this seems to be much stronger. So my ageotropic nystagmus is going to be significantly increased compared to the one that I had when I was laying on my right side. So in this case, it appears to be worse when I'm on my left, but the debris problem is still on my right. And that's the part that gets a little bit tricky for some people because they think, well, it's, the eyes are beating harder or faster when I'm on the left side. But when it's in the upward, away from the earth direction in both positions, it's in the up ear in this circumstance, so the ear that's not on the table. When I've got my eyes beating very, very quickly down towards the earth, when I'm having my excitatory response, it's in my down ear. So in the examples that we've used have all been on the right side. If it's in the posterior curve of my lateral canal, when I'm laying on my side, it's going to be on my down ear. And if it's in the anterior part of my curve, when I'm laying on my left side, now it's my up ear, it's my right ear in both circumstances. And the Bowen lean test allows you to do the same kind of analysis or framework to help confirm your traditional supine roll test. So your supine roll test, you're down and you have the patient rotate to one side, and you would expect to see the nystagmus come out for lateral canal BPPV, come back to the center position, and then go the other way. The Bowen lean test, the patient's sitting on the side of the bed, and you're going to lean them back about 30 degrees, and then you kind of bow them forward downwards about 60 degrees. So they're going to be kind of nose pointed down towards the floor, and you're going to be looking up at them. And what you're trying to create is the same effect. When I take them back 30 degrees, my canals are already pitched up about 30 degrees. This is where I get that angle back on them. Because of the way that they're shaped in this position, if I go back, if they're going to move towards the cupula and the ampulla, or if they're going to move away from it, my eyes are going to deviate one way or the other. And then when I reverse out of the other direction and I bring them forward, I should see the reverse happen out of their eyes. And so you can then begin to confirm your hypothesis from your supine roll test if you're not sure. And I'm going to dig out an algorithm on my computer, and I'll post it in the show notes here today, that talks about the bow and lean test. And when you see eyes moving in one direction versus the other direction, to confirm your supine roll test, how to analyze this and have the kind of stick ability in your diagnosis of this canal if you're unsure. So the bow and lean test comes in right behind your roll test and says, yes, you are on the right path, treat this side. So it's a secondary test just to kind of help you further support if you're unsure from your roll test what you need to do. And then the last test in here is called the supine or the sit to supine test, where you just have the patient sitting on the edge of the bed and come flat back, and you should see the eyes deviate right when they get there. So this one, the lateral canal pieces are a little bit tougher because you can't just look at one side, and you have to be able to compare intensity. We can continue on this conversation for anyone that has comments or concerns and they want to follow up more with it. This will definitely be a big part of the vestibular course that we'll be doing live and in person. We're going to become BPPV masters by the end of that weekend. We're going to go through so many different examples with this, and we're going to look at some videos of the eyes moving to get everybody feeling highly, highly confident on what's going on. Some things that we'll probably cover in some of the upcoming episodes here on PT on Ice. We've had a request for vestibular and its relationship with concussion. And I think that's a huge one to start to bring into the conversation. And there's a couple points that we'll probably talk about that. So as always, though, this show is also for you guys. So if you have any specific things that you want to hear, talk about, or address, share them in the comments, share them on the Facebook page, and we'll work them into the rotation of what we've got going. It's Thursday, so you've got generally 2 more days the rest of this week to go help people get better. So have at it. Have a great Thursday. Have a great Friday, and we'll catch you on the episodes next week. Have a good one.